funding for students. And in the degree apprenticeship documentation that Liz Hughes has put out there, it does very much indicate that the employer would pick up that deficit. And we're wondering whether the employer might be the ICB. Certainly that's happened in some other regions. So I think there's dialogue to have. We're starting that dialogue with the leads in the trusts, and we'd like to pick up the dialogue with the ICB after that. How can you help? Well, when we come to develop the PPI, we'd really like your help. Government lobbying, really helping the government to understand that we do need more medical schools, we do have a shortage, and our particular regional needs. More than any other region, 3 regions, including ours, has been named as the most under-GP'd area, alongside Brighton is another. So we really do need a GP-focused medical school for this region. And later we will really, hopefully if we get a medical school, we will really need your help to coordinate and identify the best outreach approaches with youngsters in schools. And I think that's me done.
Thank you very much, Professor Hoskins. Really interesting presentation. Any questions or comments? Joe.
Hi, thank you, Professor Hoskins. Really informative and really helpful. I work for the ICB and I'm the place director for Portsmouth, so equally passionate about having a medical school in the city. I'm really happy to help you have those conversations with the right colleagues in the ICB. So really happy to link up with you and support that conversation. Thank you.
David.
Yeah, thank you, Shreya. I think that's really powerful, and it's an issue that came up at the GP Summit last month, and I think it demonstrated to all of us how important the presence of these institutions are, not just to the city life and the richness of city life, but particularly in terms of the stickiness and then the longer term improvement in the availability of clinicians. I think the same is true around dentistry as well, from what I'm hearing. So I think that from a multi-agency point of view, anything that we can do to support, I'm afraid the City Council are unlikely to be your sugar daddy on this, but anything that we can do to help in terms of the lobbying, and certainly in terms of encouraging multi-agency engagement, then we'd be very happy to do so. And there are a couple of voices here on the ICB board as well, so do let us know when you're going to be taking that issue in that direction. Thank you.
Helen.
Thank you, Chair. I think this is an incredibly exciting opportunity for the city and the surrounding area. And as Professor Hoskins knows, we've met in public health with her team. And I think the 2 things that really stand out in terms of the benefit are that point about being a local medical school and actually looking at the opportunities. We're going to be talking about tackling poverty later in the agenda. And if we can work together across the city and the local areas to truly inspire our young people to apply locally, what we need and what we know in terms of the evidence is if you can train local people, it will not only take people out of poverty, but also, importantly, people stay locally. And as Anita knows, we do need to ensure that we build our clinical, and whether it's nurses, doctors, but also dentists, may I say, as well, locally, we do get to keep that workforce. And I'm also very excited from a public health perspective when we met, because not all medical schools are both community-based, but also thinking about how they actually support working with the population locally. And I think it gives us a huge opportunity with community projects to actually focus within the training around tackling health inequalities and prevention in a way that often, dare I say it, a lot of medical schools don't necessarily focus on prevention and inequalities. It's a very clinical medical model, and I think this gives us an opportunity really to work with the university to influence that, to actually deal with the key issues that we're dealing with across all partners, whether it's the NHS, the council, but all the broader partners, to actually make a difference in Portsmouth. So very, very exciting.
May I just come back there
Yeah,
a
please
second on that? So related to what Helen's saying, it's also about research, and designated what the research of this medical school would be doing in collaboration. So, for example, Matt's on a document at the moment where we're talking about what are the regional health needs, what are the strengths, research strengths within the University of Portsmouth, and how do we bring those two things together to find the kind of symbiotic relationship of this is the sweet spot, this is what we need to focus on in research, and then innovation as well. So particularly around medical technology, that's a big innovation area for our region and could bring lots of jobs completely unrelated to the health economy, but related to the technical economy. So we want the research focus also to be about the region and the region's needs.
Linda.
Hi there, thank you. Yeah, as a local GP, highly supportive of this project, and I'm really pleased that you're looking at diverse applicants, because I was in a school meeting the other day. My daughter's just started A-levels, and the teacher there was saying that straight A stars and A's, they're not getting into med school, which is crazy when we have a shortage of doctors. But actually, it's not straight A's that make a great doctor. There are many other characteristics of a great doctor, and I'm really pleased that you're going to be looking at that.
Yes.
Thank you. I found that really, really interesting and much needed. I'm in complete agreement. Just in terms of outreach and recruiting our future generations, I'm aware that Solent are providing a 350 plus NHS careers programme on behalf of the ICB, where they're reaching out to all the schools, predominantly in Portsmouth, primary and secondary, about all the different careers. And we can have guest speakers and do all sorts of things where we can really sell it. And that might be a really good way in. Very happy to support you with that if you want.
Thanks very much, everyone. And I'd just like to thank Professor Hoskins again for your presentation. And just to reiterate, as David said, certainly from the alongside the officer call, that the administration is obviously very much in favour of this. I know Councillor Vernon Jackson was a bit annoyed he couldn't be here for this bit of the meeting because, as we know from as David said, from the GP summit, I think he's very excited by this and really sees this as a pathway, especially addressing the GP issue that we've got in the city, but obviously more widely as well with all of those additional things. And certainly for myself, I think. Medical schools do make that huge amount of difference when you've got a university. And actually, when you look at other areas that the university has where they have significant departments that are widely seen as being excellent, it really makes a difference in terms of what we have in this particular area as well. So thank you for the update. It's quite ambitious, isn't it? It's quite an ambitious timescale, and certainly from that political side, we're more than happy to lobby and make sure, and certainly engage with the MPs as well, to make sure that we can be speaking with one voice, which is when this city does its very best, is when we do that. So thank you so much for that, and we look forward to future updates as well.
Thank you very much, everybody, for your support, and thank you for inviting me. I'll leave now you to the rest of the business, but I hope to come back and give you an update sometime in the future. Thank you.
Thank you very much. Okay, so we move swiftly on to agenda item number 5. So that's the Portsmouth Safeguarding Adults Board Homelessness Thematic Report. Over to you, David.
Thank you, Chair. Hopefully you've had the opportunity to read the report that has been sent to the board. You'll note that we saw in the board's context a number of deaths during 2020 of homeless people in the city. 12 during that particular year. Obviously it was the start of COVID and the restrictions. 5 deaths were noted in 2019, so there's small numbers nonetheless, but certainly an increase between 5 and 12. So the board decided to undertake a thematic review into some of those deaths. We chose 4 men who died during that year, tragically, in very difficult circumstances. And the thematic report, I think, is very good at amplifying the lives of those men and the difficulties that they faced, and the struggles, I think, that a number of agencies had in meeting the care and support needs of those people. The report set out a number of recommendations, and the board has now accepted those recommendations and set out an action plan, a 17-point action plan. I'm pleased to be able to report to you a number of areas where we've already made progress in respect of that action plan, particularly around homeless day services, strengthened links between health and adult social care. We have a new housing pathway, and particularly exciting, I think, is a recommissioned substance misuse service which is promoting abstinence amongst people who have drug and alcohol difficulties. The report, I think, also highlights a number of issues to do with health inequalities for this group of people, and potentially for a wider cross-section of people in the population. And the Portsmouth Safeguarding Adults Board is therefore requesting this board uses this report to write to the ICB to encourage them to explore the health-related recommendations in this report, and to explore whether they have a greater applicability across the Hampshire and Isle of Wight geography. But more particularly to encourage the ICB to consider the care and support needs of homeless people more generally as a means of exploring again the health inequality issues more particularly. So I commend this report to the board.
Thank you very much, David. Any comments or questions? Andy.
Thank you, Chair, and thanks, David. I think this is really fundamentally important. It speaks to our health and wellbeing strategy in terms of focusing on where people live and the support they receive. But it also talks to our Portsmouth residents, and we know that the risk of becoming homeless is ever greater in the current circumstances, economic circumstances that we're facing. It also provides us with an opportunity to share our learning, I think, with the wider ICB, and to get the circumstances faced by our residents that are homeless onto that health inequalities agenda, which I think would be really important for us to take that forward. So just commending the report, really. Thanks to David for bringing it here, and fully agree with the recommendations.
Thank you, Andy. Terry.
Thank you, Chair. So just a quick question around the homeless day services. Are they currently open all year round, or is it seasonal?
All year round.
All year round, thank you.
Susie?
Thank you, Chair. It's more a comment, really. I thought that's one of the most powerful reports that I've read in a long while, actually. And thank you for writing it and telling those stories, which I think is a very powerful way to get across what we're all trying to do collectively. And I've been present on the homelessness working group, and often those case studies are brought each time, and I think they're really important. But the comment I wanted to make really was the links with drugs and alcohol are obviously, very obvious in this report. But what struck me was the story behind those stories, and particularly the stuff around abuse, childhood abuse. And I know I'm sort of talking to people who are already on the same page, but I think it's worth our while constantly remembering that this starts at some point, which is not always the obvious point that we're presented with at the time, and how we need to continue to, when we're working with families and children, is to realise that this could be that 42-year-old on the street if, even though it doesn't look like it at this moment in time. So thank you, it was a really great report.
Roger.
Thank you. I obviously commend the report as well. It's an emotional read going through it. And agreeing with the two previous speakers, I think one of the themes that I read in there was that the four gentlemen were left to access or refer themselves to services. There wasn't that sort of assertive outreach approach, and I thought
perhaps that was missed as one of the recommendations, because that is something services could do. So just a comment, really. Thank you.
If I could reply to that, I think you're absolutely right, Roger, and I think one of the things that the board has been doing, and indeed at its last board meeting, we had a workshop to look exactly at that issue. Because a number of the men, not only the 4, but in the wider population of the 12, were also signposted quite frequently by professionals to services, but never got there. And it's led us to really think deeply about what further actions should the agencies take to enable those frontline staff to do that little bit extra. And I think that is one of our key themes that we want to keep working on over the next few years.
Linda.
Thank you. Again, very powerful document. I was touched in section 5.68 where they were talking about the hotel and how they actually felt safer in a hostel than a hotel. And it just makes me think, you know, we assume that they're going to want to be in a lovely hotel with a nice bed every night. Actually, that's not necessarily what they want, and we really need to be making services that are accessible and what they would like to, access themselves, and not just make assumptions on their behalf.
Terry.
Yeah, thank you. Thank you for letting me come back, Chair, if I can. Just to shadow certainly the point that Councillor Horton made, and many of us in the room will know about ACEs, adverse childhood experiences, and one of the things that we're adamant about at the OPCC is that trauma-informed practice, so prevention and looking at the reasons why certain behaviours and things are installed. So I'd encourage everybody in this room, all partners, to really have a look at their trauma-informed practice and how that weaves into the work that they do. But thank you.
Thanks very James.
Thank you, Chair. I just wanted also to add my thanks to the Safeguarding Board for the review and for the report. Both Andy Biddle and myself have shared that within our directorates to ensure that those within our service that have a part to play in securing accommodation and support have read the report and understand the findings. I'm also grateful that you recognise the context has changed since everybody in where we were using hotels, and we now have in the city accommodation which is better suited to those that find themselves in a situation where they require this type of accommodation. And equally, we're building on the support arrangements that we can make sure the support is available at the point of need as opposed to through referral systems. So there's, as you recognise, much work that's happened since. That's not to say that we should rest on our laurels, and this year the City Council and its partners are consulting on a homeless strategy. At the minute we have a separate homeless strategy covering our statutory duties and a rough sleeping strategy, and we think the time's right to merge those two together so that we can create something that looks more cohesive and seamless from the point of view of a resident in Portsmouth, and also continue to improve the accommodation and support. So it's another place in which the learning and the findings will be taken forward, but very grateful for the work of the board. Thank you.
Thanks very much, everyone, and thank you from me for the report, David, and for the it's very in depth, as has been said. It's very honest as well, and I think it really it's that point in time, isn't it? It's where we're taking a look at how things were at that point in time, but also, as James has said, things have moved on in that particular thing. There's been the new provision of drug and alcohol services, but it also shows things that don't just occur in this context, but also more widely. And actually, from Roger's suggestion, I'm going to ask then if we can just maybe put an extra recommendation in there that recognises the work that's going on about referrals. So just about recognise the work that's going on via the Safeguarding Adult Board and within the health and care system locally about referrals, and we just have that as an extra recommendation because obviously that's how we're moving forwards, and work is going on with that. So I think that's correct. We recognise that in our recommendations. But this is, for me, I've worked as a support worker for people who are homeless in the past, and you really do get that in terms of they have to, in that way they had to go out and seek things on their own, but also it is that level of just loneliness, being so alone, they feel so isolated from everything, and as has been brought out, including by Councillor Horton, the stuff that's gone on in their past is so often why they are where they are, and they've got to where they are, including from childhood. I had someone I worked with, and it was only in the last few days that I supported them before they fortunately moved on to a sustainable thing, that they actually divulged the biggest thing that was involving them, because they just felt so embarrassed and everything, that they just didn't feel like they could talk about it, because it was embarrassing to them, to their family, to everything. And yet he talked to his family at that same point, and then they were fine. And so often it's one of those things where people feel so ashamed and lonely, and they don't feel like they can divulge things, and that's just a real shame. And I think that's part of the raising that stigma as well, that being supportive can make such a difference. So thank you so much for the reports. So just to confirm the recommendations, with the addition of the one recognising about pathways into support for people who are homeless. So we have note the findings and recommendations from the thematic review, write to the Hampshire and Isle of Wight Integrated Care Boards to request that the ICB review the health-related actions in the action plan and consider whether those actions are relevant across the Hampshire and Isle of Wight ICB, and ask the Hampshire and Isle of Wight ICB to consider the provision of care and support to residents of Hampshire and Isle of Wight who are homeless as part of the ICS responsibility for acting to minimise health inequalities, and request the ICB confirm to the Portsmouth Health and Wellbeing Board the actions the ICB intends to take. So, sorry Sarah and David, you've got some work to do. Is everyone happy with that? Thank you very much. Next is Health and Wellbeing Strategy Poverty Theme. Helen and Matt, over to you two.
Thank you, Chair. So, I'm going to introduce and talk through a couple of the key points, and then if Matt wants to then add anything, I'll bring him in. So you'll all remember that poverty is the first of the 5 priorities that we are bringing today to the Health and Wellbeing Board to feed back, but also to, I suppose, also ask of member organisations what they can do. So it's coming back first, as we already had an existing partnership tackling poverty steering group. Therefore, actually, it was quite easy to come back with the action plan, and you'll note that the action plan is attached to the paper in the appendix. And really, that's focusing that action plan on what we can do as organisations and organisations within Portsmouth to mitigate the impacts of poverty. Now, we know that obviously poverty increased, and I'll give you some of the data next, during COVID, and obviously we're also now facing and already in the cost of living crisis that this country is seeing, and will no doubt have a huge impact within Portsmouth. So that's why we're coming back first with the poverty agenda, and we really want to move this very quickly in terms of the action plan and what we can all do. So just to give you an example, it's just one example. David's very much talked about a very vulnerable part of our community with our homeless population. But if I focus just on one area, which is children. So between 2015 and 2021, the proportion of children living in relative low-income families steadily increased from 15.7%, which is already high, to 21.4%. But as you know, we also always have variation in the city, and so if we lose something if we don't then look specifically at the most deprived areas of our city. So if we take, for instance, variation, so that figure is 10.3% of children living in poverty in Drayton and Farlington, to 33% 0.7 in the Charles Dickens ward. So that, just to put it simply, that's 1 in 5 children across the city, but when you really look at those specific high-risk areas, it rises to 1 in 3. And what's also shocking is that of those children in Portsmouth aged under 16 living in relative low-income families, 77.6% were actually families living, families that were working. So I think we often think of this poverty in families that are not working, but actually we're talking about quite a high figure. So that's why obviously employment is such a big factor. And I'm going to come back to that. So obviously I've mentioned cost of living crisis, which is looming it's now and it's already looming very high, which is going to ensure that we have a very, very difficult winter in terms of all public services. We've had the previous, not to be too depressing, but we've had a previously very difficult few years with COVID, and I'm afraid it's just going to only be exacerbated because of the cost of living crisis this winter. So just to mention, I've just one anecdote. Now this is anecdotal and it is from a member of staff, so we haven't actually used it in the report. But that evidence of children missing school. Now this is important because obviously we've got 5 priorities, of which educational attainment is another one. And what's really important, and we'll see as we progress with the priorities, is they all connect together. There's interaction. But we've had children missing school over the last 2.5 years because of COVID, but we're now anecdotally hearing that children are missing school due to shame as not having school uniform, equipment, money on their cards to actually attend. So rather than dealing with that, it's sometimes easier for those children to stay off school. So we wanted to give that as an anecdotal example. Now we've got on the 12th of October a workshop and we're going to do this between each of the themes as we come back. So we'll have our formal meetings doing the update, and then we'll have a board workshop and the next one being on the 12th. And it's really important. I want to use this as an opportunity to really think about what we're going to bring to that workshop and what difference we can make. And just a little reminder, because we haven't received more, but one of the actions from our last meeting, and we followed this up, was to ask each of our member organisations to send us examples of the work that they're already doing around this area, particularly sending if they've got any employment strategies around minimum wage, etc. So just a reminder, we haven't got them all, so it's a gentle reminder, can you please send them to Matt and myself? And I should have said at the beginning, Mark couldn't be with us today, but I do want to acknowledge the work that Mark Sage has done. He's leading this. I might be the champion here, therefore speaking today, but Mark Sage in the City Council is leading all of this work that is underway. So I'm not going to forgive, I'm just going to do one final thing, is I just want to remind people, because I think it's really hard, when we talk about poverty, it just seems such a huge issue for us in the city and for all public services, but it's quite hard sometimes to actually identify what is it that we can do as organisations. So there's a lot of work already happening within partnerships, and that is very clear in the Tackling Poverty Partnership Group. But what we've got to think about is what can we do as organisations for this priority. And I just want to mention a few, because it does sometimes not always clear about what we can do. But one of the things we can do, I talked about employment earlier, bearing in mind that percentage of families who are in work but are still seeing children living with low income and poverty. So what, as employees, and this is what we're going to take to the workshop on the 12th, so a bit of preparation and thinking time in between us meeting is, do all our employees receive a real living wage? Do all our employees have security of sufficient working hours to meet their needs? Can they work flexibly to ensure those with additional needs or caring responsibilities can maintain employment? And can we, through work, and it goes back to Professor Hoskins' conversation earlier about the medical school, can we, and also the response from Solent, can we ensure that we are giving our employees opportunity to progress into and through work with training and support to fulfil their potential and increase their earning power, to really lift our families, because we are big employees. If we look at Portsmouth residents, and there's a significant number of percentage of our population who work for our organisations, whether it's, you know, the council, the fire service, the NHS, etc. I'm probably missing others out, but you know, we are the biggest employers in terms of the public services locally. And just, I won't go through them all, that's in the report, and I'm sorry if it feels like, you know, but these are the things we do really want to think about when we come back on the 12th. What can we do, both as individual organisations, to actually improve the employment opportunities and training opportunities of our residents, but also to work together. And I think Solent gave a good example earlier of how we can come together, working perhaps with the university, to think about where, by doing it together, we have a greater impact. And that's going to be important for the poverty strategy, but I think also on the 12th we'd like to really focus on the cost of living crisis. So as an example, Mark and the Tackling Poverty Steering Group have looked at a cost of living checklist that we can share across public sector organisations, so we can start to really think, with suitable training, how we can identify those residents that we're seeing through our public services who are at risk of, basically not being able to cope through the cost of living crisis. So that's whether they will have health needs, care needs, or other needs. How can we work together to really support our staff to identify those most at risk? And that's the work that we're going to continue to do as we move into winter, and are looking at lots of opportunities around, for instance, how we can refer residents to our 3-phone switched on Portsmouth helpline, so that they can look at their when we've got fuel poverty needs, how we can work with the Hive around looking at where people can access food because of food poverty. So lots of opportunities that are going to come up, which we'll be talking about on the 12th of October. So I'm going to end there. I've kind of covered it, haven't I? Sorry. Is that okay? We'll bring in if there's any difficult questions, because Matt's always the person that can answer those. Thank you, Chair.
Thank you, Helen, for that. And just before we open up to any comments or questions, just to record my thanks as well, and on behalf of the board, to Mark Sage, who does a fantastic job as our Tackling Poverty Coordinator at the City Council. And he's obviously in this particularly difficult time. It's absolutely, he does absolutely sterling and valuable work for the people of the city. Any questions or comments? Lewis.
Just a quick one for me, really, just to say how good it is to actually see the action plan, how big the action plan is. And like you said, the poverty, when you think of poverty, it's such a big, wide-reaching area, but it's good to see lots of useful small things in there that actually we can all make a difference on. Just to pick out one, so for instance, like the cost of living checklist that you've got in there for where to get support from is, I think, something that's really important, because there is a lot of support out there, and we already know that there's a lot of people within the city that aren't accessing the support that's available for them. So on that one, I know the update is to get it sent out to all PCC staff, but I wondered, can things like that be shared to the wider board and to the wider members, that you were saying about how many big employers we've got? If that can go up on a notice board in a restroom at the hospital or fast, it's people aren't necessarily going to be asking for that help, but to be able to have a quick glimpse and go, oh, I might check that out while I've got 5 minutes, and it's little wins like that that will make a massive difference, I think.
I think that's a really important point, and I haven't mentioned, I know if you read the report there's more in terms of the actions. I haven't mentioned that alongside this we will be developing a very strong communications plan that will be working with our residents. And I think what's really important is even those of us that work in the public sector do not know across sectors everything that's available. So part of this is to actually communicate to residents what is available, but also have the ability to support residents using, I think it's okay for me to say, we are going to have a cost of living, just checking with Kelly as I look to the side, a cost of living spot, single point of access, where residents will be able to ring in, but importantly to actually find out what's available and resources and then be referred in. But importantly, we're having some really good conversations across Health and Care Portsmouth to ensure that goes across the NHS as well as local government and other public services, because we don't all know what's available. There's a huge amount, as you say, going on, but actually do our residents know how? And, you know, it is very complex and they need the support. Some residents will need support to actually be able to access that care. So I think really important point.
Susie.
Just on that point, because I was thinking myself about the plans that we have around a single point of access and lots of planning around how we can try and get in touch with as many people as possible. But at the same time, I think we need to hold back from over planning, because a lot of this is going to be really organic. There's going to be a lot of people who've not really needed services before who will need them for the first time. So there'll be some people who are used to the systems, and actually I think we need to be open to that flexibility. So I know when I met Lorna the other day, we were talking about the Hive, and actually is the food pantry the location for example, school uniforms? Is the food pantry the location for other information about other services, but not to then come up with a blueprint that every single food pantry needs to have this. So I think we need to just be open to a lot of stuff that we don't know already, but actually that build in that notion of flexibility and letting the needs kind of guide us to some extent, whilst having a structure and a plan.
James.
Thank you, Chair. I have the privilege of actually line managing Mark Sage, and it is a privilege, and thanks to all of those that recognise the work he does for the City Council and partners. He's actually funded by the Housing Service within Portsmouth City Council, because a lot of his work benefits the social housing tenants in the city. But I guess in there's a small challenge, and perhaps something we can come back to on the 12th of October, as to whether or not partners can do more around resourcing this area of work, given its significance to all of us and to all of our different customers. Mark will continue to operate naturally in a corporate space, but also for the 12th of October, is there more we can do to better target our finite resources to make sure that we don't inadvertently duplicate and continue to sort of help the same people with the kind of same offer? So something on the 12th of October about recognising we tend to on occasion go to some of those quick win, easy win support as part of our offer, but how can we be very much smarter and perhaps carve and sort of divide and conquer on some of the aspects of the agenda? Just some thought for the 12th of October.
Thanks, James. David?
Yeah, I think just picking up on that and Susie's comment as well, part of the way in which we're looking to design the comms around this and the data capture is to make sure that we glean as much insight as we possibly can and then learn and adapt our approaches to that. And that's something that we'll be wanting to develop with other agencies as well. And, you know, as Helen said, the dialogue with clinician colleagues has been really interesting in terms of the way in which the GPs are developing their own checklist. And I think we can learn an awful lot from one another around that, because I think, as Susie said, this is going to be a developing issue, and it is going to be touching people who maybe have not been touched by these issues in the past and in different ways. Thank you.
Thank you, David. Just on this, I mean, I think having just had our thematic report from David's last, and then we have this, I think we can't underestimate the obvious link between the two. That if we get these things right now, and we can collectively as a city be addressing some of those issues around poverty, then some of those issues that have come up in adulthood and indeed have come up during adulthood might not happen. So I think it's actually really good to have this straight after that thematic report, because it does show that link through, and the wider the wider issues that we deal with as a health and wellbeing board. So, but yeah, just thanks again for the report today. It's just for noting, as I say, is a really thing for us to think about prior to October the 12th, and I hope to see plenty of you there on the 12th of October, and it's some really good food for thought and everything for us to move forward on now. So thanks very much for that. So we stay with Helen and Matt for the Public Health Annual Reports.
Thank you, Chair. And I think we're continuing in the theme, and I'm going to pass to Matt shortly because he's got a short presentation, but I just wanted to remind us, much like the safeguarding annual reports, this is a statutory duty for the Director of Public Health and the local authority to produce one each year, and we focused last year on COVID, and I think there will be some of that continues into this year's report, because obviously the data has been impacted, and it's that post-COVID or living with COVID we're seeing still obviously in this report. Now it kind of is, I suppose, what's the phrase? Hitting two birds with one stone, I think, or something. It's an opportunity, because also this year, and I want to acknowledge, much as we've acknowledged Mark, I want to acknowledge Matt and his public health intelligence team within the work we've done, both in, I would say, the council, but also Health and Care Portsmouth. So over the past year, 2.5 years, Matt's been building the team, but also importantly building our insight and, I would say, insight, data and intelligence function, and also research function within the council. And this, we've been, one of the key priorities, although it's been impacted by the impact of COVID, was to ensure that we had a really strong joint strategic needs assessment as we move forward. It's really important that we understand our population and know their health and wellbeing and care needs. And that's why this is really timely. So we've decided to produce this year our annual report, use it on our joint strategic needs assessment. So I hope it's incredibly useful. What we also find is that people know it's there, but not necessarily a bit nervous of it or don't necessarily use it. So we are working currently, although you don't have that today, with our communications and graphics team on actually producing infographics that people can use, because I know that it's about making it accessible as important. But I'm going to pass over to Matt now, who's going to show some of the slides.
Thank you, Helen. So, as Helen said, the full report, Appendix A, goes through in detail what is our summary of the kind of key population health needs in the city. It's available on the City Council website on the JSNA page, so it's there for all of you to access. All of the analysis in that is then underpinned by more detailed pieces of analysis around specific conditions or issues. We don't publish all of those because they're generally not of interest to the wider public, but they are available on request. So there's a shared JSNA inbox that you can email, and then we can provide you or colleagues with that more detailed information if there's specific topics that you want to look at in more depth. As Helen said, we have produced a more accessible version. It wasn't ready, but it was ready at about 9:59 this morning, so I've covered it in the slides now. It is also available on the JSNA website. So that's the kind of version that I think will be more useful for people that just want a kind of at-a-glance look at what the issues are. And that's what I'm going to show you today. So I'm not going to go through the detail of the full report, because that could take us all morning, but that's there for those of you that want to look at it as well. So as Helen said, we've tried to capture it all into an infographic that just highlights some of those key issues, and we'll be working with colleagues in Healthcare Portsmouth and the Council Communications team to produce more of these, so that there'll be then separate infographics on specific topics as well. So this is a very much an overview one, just highlight some of those key issues. Life expectancy in Portsmouth is lower than nationally, and in those more deprived parts of the city, healthy life expectancy, so the number of years you'll live in good health, is 15 years shorter for men and 14 years shorter for women than in the less deprived parts of the city. So that's a significant proportion of people's lives that are then lived in poor health as well. A number of 254 deaths from causes considered preventable, and we look through what those main causes are in much more depth in the report. But they are those big issues: cardiovascular, cancer, respiratory, all of which see Portsmouth rates significantly higher than the rates in the rest of England.
And we know the issues that will improve some of those things, so both improvements to local environmental factors that we're addressing through the place-based health and wellbeing strategy, and working in partnership with colleagues across the local system, but also those key issues. Smoking, we know 14% of people in Portsmouth estimate to smoke. That rises to 27% in those in routine and manual jobs. It's the biggest preventable cause of ill health, disability and early death. We still see 12% of mothers in Portsmouth smoking at time of delivery, with all the potential impacts on long-term health that come from that. Alcohol, again, is the biggest risk factor in terms of years of life lived with disability. So and obesity there, again, 2/3 of adults in the city estimated to be obese or overweight. So those are the big issues that, from a public health point of view, and you'll all be very well aware of, but we've highlighted those in that infographic, and then we'll produce more other versions on other topics. And then the rest of the executive summary, which I've just covered in these slides, I won't go through all of it, effectively takes the text that's in the executive summary in the report that you've seen and then just presents it in a slightly more visually appealing way. So it explains, as Helen did at the beginning, what the context for the annual report is, in terms of it providing that baseline as we move out of the COVID phase and start moving into living with COVID, and how we plan services going forward. And then those key statistics that I've already mentioned. Again, I'm not going to go through all of these because it's all covered in the report, but this is what the executive summary will look like. So that's also available. So we've got a range of outputs really designed for different audiences that you can access and share with colleagues in your organisations as well. And I'll stop there, but happy to take questions on any of this.
Thank you very much, Matt. Any comments or questions? Well, I always say when there's no comments or questions that it's obviously so comprehensive and easy to read that everyone can see exactly what they need. So thank you very much to Helen and Matt for that. Obviously, this is a key part of our of what we do in public health, to be public and put it out there in terms of where we are, what the key issues are, and for all of us. Obviously, this within the council, this has a big impact on services right across the council, but obviously for everyone else in the city, all organisations, this is a really useful tool to know exactly where things are and stand. And obviously, Matt's team, and I'll join Helen in praising Matt's team, who have done a magnificent job, especially through the pandemic, where the intelligence they had really helped us navigate our way through as a council, but also the wider information that they provide, not just for the council but also for outside organisations, is absolutely invaluable. And I think making best use of the information that's provided can really make a difference, no matter what organisation it is. I'm going to ask if we can slightly change the agenda. Councillor Vernon-Jackson has a particular interest in the pharmaceutical needs assessment, so I'm sure he will be here, but I'm still going to leave it as long as we can. So if we bump that down to the end of the agenda, I'll move now on to agenda item 9, which is the Better Care Fund narrative plan. Over to you, Jo.
Yep. Thank you. Best Care Fund, as you know, is really familiar to us and a key part of our Section 75 integration between now the ICB and the City Council. We are required each year to submit an updated version of our Better Care Plan to NHS England. Dare I say it, it's usually on quite a tricky template with some tricky metrics that keep our team busy trying to work through. And obviously, because of that, we need the Health and Wellbeing Board to sign off on the plan each year. It's a really important plan for us, as I've said. Probably fairly little changes each year, if I'm honest, because this is most of the funding in the BCF is how we bring our services in the community together. So a lot of the money is spent on those services that are a core element of our delivery to prevent people from going into hospital, to support early discharge from hospital, and to prevent people going into long-term care. So it funds familiar services for us in terms of PRRT and our embedded reablement services such as Spinnaker and now the South Sea unit. It also provides quite a lot of our voluntary sector service response as well that we fund jointly. Having said that, not necessarily reflected so well in the plan because of where we are in the planning stages, but what we will see in the BCF through the course of this year is some changes to the schedule as we've increased new schedules, as you know, as part of our strengthening of that integration. So some of the smaller elements of the BCF services that are provided will move into other services. So safe space, for example, will move out of the BCF schedule and into the health and wellbeing schedule, and some of the mental health services will move into one of those other schedules. So we have a much more focused look on how we spend the money in those areas. Gosh, I've broken the microphone, apologies. Sorry. And then the only two other bits I just wanted to flag are the work we're doing around bringing together the South Sea unit and consolidation of Jubilee. So again, how we fund that will be really central to the BCF. And then the other work that we're doing with the Hive and the Red Cross and Salvation Army around really strengthening our voluntary support offer, again, to make sure that we're targeting those most at need of, or most at risk of avoiding hospital admission and supporting those that need to come out of hospital quickly, and making sure that those services are much more embedded with the statutory services and with PRRT than they currently are. So lots of work going on around that. But they're the kind of the main changes. So hopefully you're happy with the plan for this year.
Thank you, Jo. Any comments or questions? No, thank you so much for this, Jo. It's a very key report again to give us the idea across our systems how the Better Care Fund is going forwards and what the plans are. This is a really key part of our integration that we're so proud of in the city, and the work that's been going on to make sure that continues under the new governance arrangements of the NHS in our area. So thank you very much, Jo. So on to agenda item 10, autism and neurodiversity. Over to you, Claire. Very welcome.
Thank you. Do we have slides? Lovely. Okay. So I've come to talk to you today about a piece of work we've been doing in adult social care around autism and neurodivergence. We are taking a slightly different language approach in adults compared to what children's are doing, simply because we're being led by our autistic and neurodivergent community in the city, and I can talk about that a bit more if anyone has any questions. So I'm going to talk to you a little bit about some work that started in the middle of last year and what we found. I'm starting with a quote from the chair of our autism forum in the city, Veronica Price, who would have joined us today if she'd been able to. Society's prevailing narrative of autism has been largely informed by so-called experts from the non-autistic world who have perpetuated partly or completely inaccurate, misleading and dismissive views. I think it's fair to say we haven't pulled any punches in this work. We think it's really important to actually communicate how the autistic and neurodivergent community are experiencing us and our services. So, for those who aren't familiar, the Portsmouth Autism Community Forum is an open forum for autistic and neurodivergent people, carers and professionals, and this work was carried out on behalf of and in partnership with that forum. So the work was seeking to understand how autistic and neurodivergent people are experiencing public sector services, what's working, what's not working, where there are gaps, what the level of demand might look like for new services, and what level of resource might be required, and also starting to gather some priorities for a new strategic plan and making sure we were linking into other work that's taking place. So, data isn't great, unfortunately. There's no accurate data due to underdiagnosis, misunderstandings and misdiagnoses, both in the population and in the world of medical professionals. The estimated prevalence of autism specifically is between 1% and 2% of the population. More recent research is suggesting that it might be likely to be more like 3%, higher prevalence in deprived communities. When I tried to interrogate System 1, our shared record system, there were 1,010 active patients with an autism or similar diagnosis. Basically, the data that I interrogated, nothing matched up and nothing made sense, so we basically disregarded it. There's a huge potential to prevent worse health for autistic and neurodivergent people in Portsmouth. Autistic people specifically are at double the risk of dying due to virtually every cause of death. The reasons behind that are not well understood. But I'll go on to speculate a bit based on what the autistic community told me. Autistic adults who don't have a coexisting learning disability are 9 times more likely to die from suicide. That increases to 14 times if you're an autistic woman. And the average cost of suicide is £1.7 million. So there's a clear a clear reason right there, let alone anything else, to be investing in better support for autistic and neurodivergent people. It's currently hard for most autistic people to access standard health and social care services. The way that we communicate with people, the way we require people to interact with us can be quite rigid. Even when we think we're being person-centred, often we're not, and the autistic and neurodivergent people will try to fit in with what they perceive to be what the neurotypical world is asking of them. So, you know, just again, that in itself, improved communication, improved personalisation would make a big difference. The Office of National Statistics data shows that just 22% of autistic adults are in any kind of employment. So again, there is huge opportunity here in relation to the tackling poverty agenda and in terms of improving both health and well-being and economic well-being. So data has shown that autistic people are least likely to be in work out of any other disability group. There is a clear legislative and policy context behind this work, which is good news. The Autism Act, I haven't updated that, was the only disability-specific legislation until the Down Syndrome Act came in earlier this year. The Care Act is really clear in terms of the social care obligation to offer assessment and support. There is an all-party parliamentary group on autism which published a really, really powerful report back in 2019. The NHS long-term plan references the need to improve support for autistic and neurodivergent people. Despite all of this, we're not alone. All local authorities have struggled to implement the legislation and policy due to a variety of factors, and the pandemic obviously hasn't helped. So the existing service offer in Portsmouth, the only real avenue for understanding what's going on for someone in terms of their social communication differences is a formal diagnosis. And the wait for diagnosis in Portsmouth is currently more than 2 years, more like getting towards 3 years. Autism Hampshire are our current provider for post-diagnosis support and information and advice. It's a fairly traditional kind of service that they offer. It doesn't meet everyone's needs, and lots of people feel that it's not local enough. So there are certainly things to be improved there. There are small numbers of people being supported adequately, and in some cases well, by adult social care and our occupational therapy colleagues. When I interrogated System 1, the adult social care unit, lots of people were being bounced around. Lots of them were likely being signposted, which is really ineffectual for autistic and neurodivergent people often. Unfortunately, I heard no positive experiences from autistic and neurodivergent people in the city about their interactions with mental health. Often people found interactions with mental health actually quite traumatizing and exacerbating whatever it was they had going on. So in line with the mental health transformation work, there's huge opportunity there. And in the community, there are pockets of support scattered across different organisations, some of them voluntary sector organisations, some of them more informal community sector. Currently, the existing service offer is a bit patchy, and it just basically isn't working well for people. So I spoke to 90 people in the course of doing this work from the middle of last year, and this was a real standout headline for me from one of the autistic people I spoke to. People's lives are blighted by being subjected to services. Now, none of us are here to blight people's lives with our services, are we? But that is how people are experiencing particularly health and social care services, but also the benefit system, housing services, and so on and so forth. As I mentioned, the public sector is difficult to access for autistic people. This can mean that we think, as providers, that we don't hear from autistic and neurodivergent people, and therefore they're hard to reach. When an autistic person becomes known to a service, it can be hard to secure engagement, so we might try a couple of times and then discharge them from our services. It means we don't have data around what autistic people want and need. And it's those inflexible communication methods that I already mentioned that create really a concrete wall to people actually being able to access support. And a big reason behind this actually is that there's really no adequate training or workforce development at the moment, so that's something we know that we need to focus on. So we can share the full report for those who haven't seen it, but I made a series of themed recommendations in partnership with colleagues from the Autism Forum. We know that we need to improve people's experiences of the transition from adults to children's services. Often people feel quite well supported in children's services, and then they reach adults and there's a cliff edge that they just fall off. So in adults, we already have recruited a transition lead, and we have new staff starting quite soon who will be able to provide some specialist support. We're also improving our strategic alignment, and myself and my colleague, who's the transition lead, are sitting on the Children's Neurodiversity Delivery Board. We know we need to improve support, including specialist support from adult social care, and that's something we're working on at the moment and have started to develop with a new one-stop shop based at the Charles Dickens Centre. We know that we need to improve the training and workforce development offer. Some of that will be in line with the new Oliver McGowan mandatory training, which is coming in through Skills for Health and Skills for Care at some point, hopefully quite soon, but we'll also be looking at what that looks like more generally for people who aren't in health and social care roles. And we are committed to any training being developed and at least partly delivered by autistic and neurodivergent people in the city. We feel strongly that we need to develop public knowledge and improve understanding and acceptance. There's still a lot of stigma that exists. My feedback from the Safeguarding Adult reviews have been, I wonder how many of these people have some kind of a neurodivergence going on, which has made it really difficult for them to access support and difficult for them to communicate their needs. And actually, stigma is sometimes partly to blame for that kind of situation where people don't want to label. So we need to think about how we support people to understand what's going on for them without shoving on a kind of medical label. We need to improve access to health support, particularly mental health, and I've been working with the team who are leading on the mental health transformation work to ensure that whatever that ends up looking like is inclusive and supportive of autistic and neurodivergent people. And we think we need to build on research, something that I've already spoken to Matt about briefly, and this cohort of our community are often just really not well understood, and we know that evidence would improve that situation in terms of what we provide in the public sector. So there are some projects already starting up. I won't go into these in a lot of detail, but there is a Support into Employment project. We've started building some video resources to support that training offer I was talking about. We have a peer support group, and the Serendipity group is through Autism Hampshire, so those are kind of social peer support and kind of self-learning type of groups. There are some art sessions delivered through Co-Create, and as I mentioned, we have the new community room at the Charles Dickens Centre. The important thing to note about all of these things is that they are funded either short-term or not funded at all. We are obviously going to be actively seeking funding, and we will be seeking to mainstream some of this stuff when the opportunity arises. So what next? My ask of you today is to think about how you can be the change, how you can support the development of a new strategic plan, and how we can all kind of take ownership for better supporting our autistic and neurodivergent friends, colleagues, neighbours, so on. So a good starting point, if you're not already knowledgeable in this area, is to improve your own knowledge, understanding and acceptance. I think we think of ourselves as quite inclusive in the public sector, but if we don't understand what social communication and information processing differences look like, then we can't tailor, can we? Because, you know, it's a sort of catch-22. So I'd ask you to ensure the people you know, or, you know, in your personal life and in your professional life, support them to gain knowledge, understanding and acceptance, and to scrutinise your service areas. Are they accessible to neurodivergent people and those with sensory and communication needs? Again, we often think that we are being flexible, but when you really scrutinise it, we're quite possibly not. So that's it from me.
Thank you very much, Claire. Any comment? Oh, Andy, straight in there.
Thank you, Chair, and thanks, Claire. I'd echo Claire's comments at the beginning. My great thanks to Veronica Lake, who's the chair of our Community Autism Forum. Veronica is an essential part of our network around this work, and it's a shame she couldn't be here today. I guess it feels a bit like the poverty stuff. It's huge, because actually it affects so many people in our community, and we're such an early starting point, and I'd echo Claire, we're not the only local authority in that place. I think the really important thing for me about all of this, and the progress that we've made thus far, is it's all been in conjunction with people with lived experience. It's something we as a council do, it's something we as a council prioritise, and a lot of our colleagues in the public sector in trying to shape whatever help and support is needed with those people that experience it, so we try not to get it wrong. I think it touches all of our services, and I think we've had tremendous support, acknowledgement and acceptance from all of those colleagues that we've talked to across services in Portsmouth. I think the other thing that we're doing is shaping our action planning with people with lived experience, so there's a lot of authenticity to that. And I think taking a lead in many ways from our children's social care colleagues, we're moving as far away from diagnosis as possible, because whether you have a diagnosis or not, and we've seen the average weights there, if you're experiencing difficulties and you need support, then the diagnosis is irrelevant. So thanks to our children's colleagues for leading us in that. I commend the report, really. I think it's really important stuff. It affects all of our services, and there's a huge amount that we can do that won't cost a huge amount of money. But there is, of course, that pitfall that much of what we're doing is short-term funding. Thank you.
Helen.
Thank you, Chair. I'd like to agree with everything that Andy said. A really interesting report and presentation, Claire. I think two things that struck me there, because I recognise your point about we need more research, but I think there's already quite a lot of research that is applicable. You know, those with neurodiversity, children and adults in our community, are a vulnerable group, much like I would say, you know, are those who are homeless and those with mental health, that often, and this isn't meant as a criticism, but our services focus on their specific need around emotional, mental health or education, and not on their physical health needs. Now, we know what causes, you will hear me have ill health, disability and early death. And, you know, Matt's shown that today. We know that those are, you know, those things are caused by lifestyle behaviours that then cause diabetes, cancers, heart disease, diabetes. But actually we don't do enough to focus on what actually causes that. And I'm not saying it means we have to rush out and push our services around trying to encourage people not to smoke, to eat healthily, be physically active. But we know that those in those vulnerable groups are more likely to take up those lifestyle behaviours, and often not then supported not to take them up, because it's kind of seen, dare I say it, as well, they've got, you know, this community got a lot going on, does it matter? And I don't mean to give the impression that we're complacent as public services or that we are maliciously trying to do something, but I think the reality is it's often not dealt with. Therefore, we are going to see this continue, feels a bit harsh, unless we actually look at all of those communities. We know that people with serious mental illness can die up to 40 years earlier. We know that people, our homeless community also, and other vulnerable groups, and our residents with neurodiversity are no different. And I suppose the other, which is related, I think we do tend to wait for diagnosis before we put some of that input. And I think, again, on the work that Sarah and Andy are leading around this, it's really important we don't always wait. I know there's a lot of pressure for diagnosis, but to start, and how important that kind of make every contact brief interventions are, and then the support that is applicable and appropriate for this group. And also the other thing that strikes me is we know, and you've presented it, we know that one of the most, the best things you can do for your emotional and mental health is actually be in a workplace. So for me, that seems to be where we should really, really focus. If we can ensure that there is appropriate and the best employment opportunities, which goes back to our poverty discussion, I think that's really, really important. It will make a big difference. But a really good report. Thank you.
Thank you. Susie.
Thanks, Claire. That was a very punchy report and landed well. I'm just sort of curious about the generational difference here, because I obviously know a lot about what goes on in children's social care, and I also know I was a teacher when the people that you're referring to were in school. And I'm often asked this question, and we all are, aren't we? Has neurodivergence increased, or is it that it wasn't diagnosed? And it's probably a kind of combination of both. But I suppose, and I know I could ask Sarah this later in our meeting, but my call to Sarah and Andy is, we also know sometimes that this is generational within families, whether that some of the services that we can look at can actually be supporting adults and children as a family, as part of our wraparound service. So that was I just wanted to sort of mention that here. I'm sure you've already along that line, but thank you, it was a really good report.
Please, Claire.
It's really cheap, it's a virtual session which you joined to receive the training, and the objectives are then about being that positive voice for people with autism, considering the best ways in which to communicate with people with autism, and again across our organisation, particularly for those that come into our custody, that's really important, how we're communicating. It's about making the environment suitable for people and listening to what their needs are, but communication for me is the absolute key to this, and I think where we potentially do have that gap between children and adults, particularly those that have been through education and been used to scheduling, text symboling, and that real visual representation of what their life is going to be that day, that week, that month, that's what we lose when they then transition into adult services.
Joe.
Thank you, Claire. And I echo what Susie said, a really powerful report and really hard-hitting, but probably what we need to move this forward. And again, I'd echo what Andy and Helen have said. It does feel quite huge, but there are lots of things we can do and get better at that won't cost huge amounts of money. And you mentioned the mental health transformation and how important linking this work has been with that. And I just wonder how many of our other transformation work, and particularly taking account the physical health needs, some of these people, are we linking that up properly? And I suggest we're probably not, but really keen to work with you and to sort of share the report and the findings with the team so that we can get better at doing that.
Yeah. Thank you. Can I come? Thank you. Some really interesting comments. I mean, I think prevention is at the core of this, and I do really hope that the work that Children's have started around the neurodiversity profiling, which really allows you to really understand what's going on for that individual, what are the differences that are presenting problems, and how can you plan to kind of mitigate and work around, and and the understanding of self, I think, is key. So I do hope that we'll see fewer people actually needing to come through to mental health services. You're right, Joe, lots of autistic and neurodivergent people have coexisting physical conditions, some of which seem to be genetically linked, but there's, that's not well understood at this point in time. I have spoken to some of the physical health services, the long-term conditions people, for example, about their understanding and awareness, because I know they see a higher prevalence, for example, in some of those in those cohorts. I think in terms of health prevention, I think what's not quite so well understood is where certain interventions don't really work for autistic and neurodivergent people. So in mental health, where there's the focus on recovery and particular pathways, sometimes those pathways are too rigid. And I would assume that, again, it's not well understood, but I would assume that some of the pathways used in other maybe substance misuse, and I did have really amazing conversations with our colleagues who run the substance misuse, alcohol, homelessness services, who were all hugely interested in this because they could name people that they were working with who they thought probably were experiencing ADHD, or maybe it's adverse childhood experiences. It doesn't really matter. What matters is understanding what's going on for that individual and tailoring your approach so that it works better. But you're right, Helen. This is the whole population we're talking about. Some academics think up to 20% of the population could be neurodivergent. Quite possibly in 10 years' time we'll be saying diversity, divergence, what does it matter? This is about personalisation, making sure that things work. But I think it's about prevalence and building the workforce's understanding so that they can make that first step in tailoring things better.
Terry.
Yeah, just one very quick point, sorry to come in late, but I think the point about communication is absolutely key, isn't it? About all services working together and speaking to each other. We all lead very busy lives, but as employers, I think it's really important that we are making time for our staff to be able to communicate with various services. Education is a key one, isn't it? The police, and so often when the OPCC, I think we find that there are situations that could have been prevented if we had had that conversation and prior knowledge. So I think we really do need to look at communication. As employers, many in the room, we're probably best placed to ensure that there is time and facilities to be able to do that so that we're all talking to each other.
David.
Just wanted to thank you for the report and also to kind of emphasise that area of grey. Sometimes people with autism or a neurodivergence, it's obvious that that's what they're presenting like, but there are, as you said yourself, wondering about a number of people in the adult world, serious adult review cases where they may have an autism or a neurodivergent condition, which sometimes is, looks very much like an adverse childhood circumstance. It's a trauma, sometimes looks like trauma. And I just wonder about, in those contexts of some of the people that we sometimes describe as difficult, and we condemn as a consequence, but may actually underlyingly have a condition that if we thought about differently, we'd react to them differently.
Yeah. And I think we undervalue what can be achieved sometimes. Sometimes, people have had a lifetime of experiences of the public sector, had a lifetime of feeling that they're working against the rest of the world, or that the rest of the world is, doesn't fit in a way that they can make it work for them. And actually, we expect change really quickly often. I mean, we're not great at understanding behaviour change theory, I think, generally, and that's something I think we need to improve generally across health and social care, and taking responsibility for that kind of making every contact count type approach. But for autistic and neurodivergent people, you've got to accept that often change is going to be looking different. It may, for some people who really like structure, sometimes the theory might literally make the change, but if we're not using it, and for some people there's so much else going on that actually you need to think a bit differently about how we can affect change.
Thank you everyone for your comments, and thank you so much, Claire, for your presentation, and for everyone who's involved in putting that together. As people have noted, and you said, it doesn't pull any punches. And it really is, I think, a wake-up call for all of us to do the very best for people with autism and more generally neurodivergence. I think that the employment one was really start for me, and I think I don't think we can underestimate the power of peer support in that way, especially for people who are neurodivergent, who are in employment, and about the difference that can make, and create that real aspiration as well. It's interesting, I know a few people who are older with who are neurodivergent, and for them there was no expectation of employment, so they've never had employment, and it's almost like, well, I've got this, so I can't work, and that's just real. That's just become almost a given. So changing those attitudes, and also the stigma from outside about, someone's neurodivergent, autistic, they can't, they're not going to be any good, they're going to be really difficult, as David was mentioning, difficult to deal with. What does difficult mean? It means that you don't understand how to do that, and so we've got a lot of work to do there. So thank you so much for that, and thank you for your challenge to all of us as well. Councillor and Jackson, welcome. Just to let you know, the item on pharmaceutical needs assessment we're going to do last. Did you have any declarations of interest?
No, and my apologies that I'm juggling several meetings at once.
Okay, so Kelly, revised Health and Wellbeing Board terms of reference.
Thank you, Chair. Just to take you through this really quickly, the report covers two issues. One is the recently published draft guidance on health and wellbeing boards and how they'll operate in the light of the new NHS structures. All the recommendations in it seem to indicate a high level of continuity, and we've also responded to the consultation on behalf of the board, and that's attached to the report. In light of that, what we're suggesting is that the terms of reference review is a very light touch one at this stage, which really reflects the changes agreed in the last meeting, which was around the formalising the new members, which include Hive Portsmouth, housing representation, opposition members, and also the Office of the Police and Crime Commissioner. And we're also recommending that this is presented to Governance and Audit Committee for inclusion in the Portsmouth City Council Constitution. One amendment I would like to suggest in response to feedback received is that we also include within the terms of reference that the board will take on responsibility for the serious violence duty as part of its community safety duties. We'll reflect that change, and would also like to flag to you that the Combating Drugs Partnership will be coming to the next meeting, which is a new requirement, and they will be speaking about how their governance will fit into the Health and Wellbeing Board structures, and we may need to consider changes in response to that. But at this stage, it's a very minor change. Also reflects, obviously, that we're now not talking about our CCG colleagues, but our ICB colleagues, and that's picked up there as well. So no significant change, just formalising that membership, highlighting a couple of changes in future, and flagging there will probably be more significant changes required when the final government guidance is issued. Thank you.
Thank you, Kelly. Any comments, questions? No, thank you so much, Kelly. Yeah, I mean, it's as you say, little change at the moment. More changes on the way and more clarification when we get them. But I'm very happy to propose that we go forward with this revised constitution. Is everyone happy with that? Perfect. Thank you very much. On to Joe, GP Summit update.
Yep, conscious of time, Chair, so I'll just keep this very brief. This is just an update to the report of the GP Summit that we had back in August, which was as a result of some of the challenges we're facing in primary care and GP workforce in the city. It was a really positive event, and I think really welcomed by our GP colleagues. We've had a number of follow-up events and some actions that we're continuing to progress, including, working with the university on the medical centre, medical school, and the reason for that report coming here today. Also looking at international recruitment and areas where we can support our practices to do that more effectively. And again, lots of other work going on around the communications, and it's not going to be an easy fix, so lots of work going on, but it was a really positive event to raise some of the issues and to share that understanding that with the challenges we're facing in primary care with across a wide range of health and care partners. So thank you.
Thanks, Joe. Any comments, questions? Gerald?
Yeah, well, just to build on that, and thanks to Joe for your work and everybody else. I think there were some really interesting things to flow out of it, and we'll need to do a follow-up one, and we probably need to have a wider invite to that, because I think that would be helpful. I think some of the things we picked up, as Joe said, was that the long-term help will be the establishment of a medical school at the university, so we're able to grow our own, because then a proportion of them will want to stay in the city, as a proportion of all students do. That if we can get primary care to be able to use some of the services that QA have for being able to fill job vacancies that they're not able to fill locally with international recruitment, and to be able to opt into that service so we don't have to reinvent the wheel would be helpful. I think there are also some other things that we can look at to see if we can address. So we've got too many GPs retiring early, because there's an issue with the government rules about the pension pots, and therefore people thinking that it's not worth their while carrying on, and in a city where we are really stretched for GPs, that's a problem. Issues with the Home Office and not giving visas to GPs who want to stay and work in the UK, and therefore losing them out of practices. So Eastshore are losing somebody because the Home Office haven't sorted a visa, and that's a real issue. And then an issue with training our own, as we've got very, very hard-pressed GPs in the city, asking them to then supervise and train the next generation. And Linda here is somebody who trained somebody in Portsmouth and then stayed. We've got people who want to be students and trainees in Portsmouth, but the way in which trainers now need to have a postgraduate qualification before they're allowed to be a trainer is putting people off when they're really hard pressed as it is. So there are some systematic things that we can do to address things, but I think it's been really helpful, and we'll need to get everybody together again, because I think we have the ability to make a difference and hopefully support the medical practices in the city to be able to provide the care that everybody wants.
Thank you, Gerald. Any other comments? Okay, thank you. And just to reiterate, I think it was an incredibly worthwhile event. We've, as Gerald's mentioned, we've had some, and Joe's mentioned as well, we've had some follow-up meetings already. We will be, reconvening. What I thought was really helpful as well, actually, was we actually had some people from outside the city. So we had colleagues from Southampton there. We had some from Fareham as well, because though in the stats as they were done, we were the area that had the lowest proportion of GP per head of population, but actually those stats hid quite a lot in terms of needs within bigger what were then CCGs as well. So us using our close relationships, our integrated way of working that we have, and being able to share what comes out of here, I think is really important as well. Because if we have solutions that work for here, they're going to work for elsewhere as well. Joe, you want to come back in?
Around the work with the Health Education England and who manage the training and the trust. We're working with colleagues from across the ICB on as well, so we get that broader engagement as well, and others can benefit. And I'd just like to say that the practices really welcomed as well the visit that you did to one of the practices, because I think that really again helps to raise understanding on both sides, the challenges they're facing and all the work they're doing to improve things, but also the public perception and the challenges that the public are having around access. So building that common understanding and working together and helping each other has been really valued, so thank you.
Thanks very much. Okay, so and obviously this will be a one where we will keep people up to date on the Health and Wellbeing Board on a regular basis as things move, and obviously it all fits in with also the medical school as well and their journey. Okay, so back to agenda item 8, pharmaceutical needs assessment. Matt, over to you.
Thank you, Chair. So just to briefly give some background, Health Wellbeing Board has a statutory duty to publish a statement of the needs for pharmaceutical services, known as a pharmaceutical needs assessment and referred to from now on as a P&A. We have to publish this by the 1st of October this year. The content of the P&A is specified in the 2013 regulations and remains unchanged from the previous P&As published by this board in 2015 and 2018. We published the draft P&A for consultation as agreed with Health Wellbeing Board in March, and we're now seeking final approval from the board for the final P&A. The draft P&A concluded that with 37 community pharmacies, 1 distance selling pharmacy, that the location, number, distribution and choice for pharmaceutical services serving Portsmouth residents meets the needs of the population. It didn't identify any need for further improvements or better access to services based on current provision. The key points in those conclusions are summarised in the executive summary of the P&A, which is attached in full Appendix A to the reports, but those key conclusions are based on a number of things. The total population of Portsmouth is within 1.6 kilometres straight line distance of a community pharmacy, which is one of the national standards that's used. There's good geographical spread of community pharmacies across all localities in the city and within communities experiencing greatest deprivation. We've got 17.2 community pharmacies per 100,000 population in Portsmouth, which is slightly higher than the average for the rest of Hampshire and the Isle of Wight, and broadly in line with the national average. 99% plus of the population of Portsmouth are within a 20-minute walk of a community pharmacy. And there's good coverage in terms of specific opening hours. We've got 4 100-hour pharmacies, supplementary hours in other community pharmacies, and services in neighbouring Health and Wellbeing Board areas. All pharmacies provide the full range of essential services, and there's good provision of advanced services and a range of enhanced and locally commissioned services as well, with good geographical spread, and the detail of all of that is covered in the report. Section 4 explains, 4.1 explains that P&A is used by NHS England when deciding if new pharmacies are needed in response to applications by businesses. Those applications are contested by applicants and existing NHS contractors and can be open to legal challenge if not handled properly. And section 4.2 sets out what's required as the content of a P&A. So we've prepared the P&A, set out Appendix A. It's overseen by a joint steering group across Hampshire and the Isle of Wight to ensure a consistent approach across the ICS system, and with the steering group including key users of the P&A from NHS England and the local pharmaceutical committee as well. Section 4.3 covers the feedback to the consultation, which was sent out to members of the Health and Wellbeing Board, existing pharmacy providers, neighbouring Health and Wellbeing Boards, and other key stakeholders like the local pharmaceutical committee. 100% of respondents agreed with the conclusions of the P&A, and therefore only minor changes have been made between the consultation version and the final version, none of which affect the conclusions that I previously set out. It's worth adding, though, that during the time this final P&A was being prepared, 2 consolidation requests have been received. So that's pharmacies that have requested to consolidate from 2 sites into 1. The Health and Wellbeing Board response was submitted to NHS England following the process agreed. Those decisions haven't yet been made, so they're not reflected in the current P&A and can't be. But if changes do take place, then the Health and Wellbeing Board can agree a supplementary statement that updates the P&A in light of changes that have happened during the 3 years that the P&A exists for. On that basis, we're asking the Health and Wellbeing Board to agree the recommendation in 2.1 to approve the P&A for 2022.
Thank you very much. Gerald.
Thanks, Chair. I had a very useful and interesting briefing from one of the 4 big pharmacy companies in the country who highlighted the issue with the pharmacy contract that the government has with pharmacies up until, I think it's the end of 2024. They're saying that for community pharmacies, it doesn't work for Boots. Boots is slightly different, but for most of them, 90% of their income comes from the NHS, and the pharmacy contracts are cash limited and therefore not inflation contracts. Their expectation to me was that by the end of 2024, 75% of all community pharmacies in the country will have shut because they will not be economic on their contract the government has given them. Now, that may be over the top, but I think it's extremely worrying in a city where we have huge pressure on GPs and where we're looking to pharmacies to take some of that pressure off so that instead of it going up the line from GPs to St Mary's, so the minor injuries unit and then up to A&E, we're trying to take pressure down the other way. And if we're going to lose a very, very large proportion of our pharmacies, that's quite worrying. The other piece of feedback he had for me was that in Scotland, all new pharmacists are qualified as they can give prescriptions. So gradually across the whole of Scotland, all pharmacists will be able to give prescriptions out. Wales is looking to follow suit, but the NHS in England have not been interested in going down this line, which I think is worrying. I have 4 amendments I would like to make to the report, and with your permission, I'd like to read them now. I don't think it changes things enormously, but I think it reflects the position that we're in. When Matt talks about consolidation, I think we have to be clear this is about closure of pharmacies and removal of services to local people at a time when we need pharmacies to be doing more, not less, in the city. So at the end, so on page, all of them, my amendments are on pages 140 and 141. So section 1.2 and 1.3. At the end of 1.2, and at the end of the first paragraph, I'd like to add a second one. which says, as the city with the worst ratio of patients per GP across the country, pharmacy services are a crucial part of primary care services in the city. Because I think it's really important to say how important it is and why it's important. Then at the end of paragraph 2, in 1.2, I'd change the full stop into a comma and put, and there should be no reduction in pharmacies. At bullet point 4 talks about that 20% of people could get to a community pharmacy. Most people can get there in 20 minutes. I think we need to reflect that that's not true for people with limited accessibility. It's fine for me. I can walk there in 20 minutes. Somebody with a walking frame can't. And I think we need to put in something that says this does not reflect the access for those of limited mobility. And then on the third bullet point in 1.3, the last line, it says the provision of services, so further reduction in provision of services could require an update assessment. I would like to return that from could to would, so that we would definitely come back and look at it if we do have more reductions in pharmacies across the city proposed. I don't know if people would agree with that, but I just think those things strengthen it a bit, and they're not out of line with what the consultation responses came up with. And Matt is nodding at me, which is I'm very pleased with.
Terry.
Yeah, no, I would certainly agree with that. Just a point of clarification for interest, really, Gerald, if you're happy to answer. What was cited as the reason for the government not following the Scotland or Wales model in terms of prescriptions? Do you know?
I think Jo can answer behind you, or she's waving, and she will know more than me. I think it's what goes through the minds of NHS civil servants in Richmond House is beyond most of us, and I think it defies logic most of the time, and this is another example. But Jo will be able to enlighten us.
Thank you, Gerald. So I did go back to Simon Cooper, our Director of Medicines Optimisation in the ICB, on our local team, and to be fair as well, responsibility or delegated responsibility for commissioning optometry, pharmacy and dentistry has moved from NHS England to the ICBs from this year, and we're continuing to develop that, so it's very early for us.
So Jo, we're going to have one pharmacy for the whole of Hampshire?
No, of course not, Jo. So I just wanted to clarify a few points, really. Firstly, around all the pharmacies closing piece, I think it is that may be a do-nothing scenario, but the contract is being reviewed, so we would think that it would be very unlikely that we would see that level of closure of community pharmacy that's perhaps being, prophesised. But we will continue to work with NHS England to understand that and to raise those concerns and challenges, because you're absolutely right. We do see that community pharmacists and pharmacy colleagues are absolutely essential to supporting people in that self-care, self-management and moving work away from the GP. And actually, about some of the consolidations that we've got locally, that has prompted some conversations that the Meds Optimisation team are having with community pharmacists and Solent to see if there are things we could do differently, because that advice and being able to walk in to community pharmacies is so important, and not just to our primary care colleagues as well, but to members of the public. On the pharmacy prescribing issue, I will get some more detailed information out to you all so that we can really clarify that. But my understanding is that all new pharmacists, so those coming out of training, will be accredited prescribers from 2026. So that is UK-wide, so does include England, but perhaps the piloting of that has been taking place in Wales and Scotland, not in England. So that means that, but that doesn't necessarily mean that each community pharmacy will have that prescribing opportunity, but there will be more pharmacists who can do that prescription. But I will get some more detail that perhaps can be sent out to the board from the Meds Optimisation team that just really clarifies that position, because it is quite a complicated one, I think. But hopefully that helps. Thank you.
Thank you for that, Jay. So, Gerald, Susie?
Sorry, I've got an opinion on everything today. I just wanted to pull some of the strands of other stuff that we've been talking about into this context, because having read all of the reports and Helen's report as well, sometimes these decisions seem counterintuitive to a lot of the other direction of travel that we're going with. And you know, I love a case study, but this one is a personal one because, as some people in this room know, I'm a carer to my mum who lives independently and is in her 80s, but she's a full-time carer to my nan who's 104 who lives with my mum. Now that saves a lot of money in many, many ways. The other point to this is what I have learned, partly through the pandemic and moving in with them, and actually it's a shame Andy's gone, because one of the things I had a lot of conversations with him is actually that importance, that crucial part of health in remaining independent. And I hadn't felt it so keenly as I did until I moved in with my mum and nan, and often as younger generations and carers who are for our parents, we want to make them safe by taking away their independence, which of course then unwittingly then undermines their health outcomes and lessens them. And the reason I mention this is my mum's pharmacy is one of the ones that is due to be closed, and she will not be able to get to the other pharmacy. But that pharmacy is literally a lifeline, not just in terms of a medication, but in terms of knowing the pharmacist, knowing the needs, being able to, for someone who can't manage IT and a lot of technical stuff, and being able to go and being understood. So the other things that we've been talking about is about being understood. And I just wanted to actually take this report, which is very rational and rationalising things, and just put that kind of human context on it, but also the financial and the health aspects of these decisions are really, really, really crucial. And I think the challenge around what sometimes is a logical approach, and I understand the difficulties and the finances and everything, but actually what are the unintended consequences of that in terms of the costs that will be picked up in other areas by closing a local community pharmacy. So thanks for indulging me, but I do feel really passionate about this.
Helen.
I think that's an incredibly good case study, actually, Councillor Horton. And there are, I don't want this all to be focused. I think that Matt is very constricted on how, ultimately, NHS England have been the commissioners. It's now moving, which I think will be incredibly helpful locally, because we'll be able to use our local intelligence to make some of those decisions. So P&A report aside, I think also what you raise is really important in terms of the broader conversation we've had today, because ultimately we've already discussed the fact that we don't have enough GPs and primary care is really impacted. We've also recently discussed, we know that we've got one of the lowest per head of capita GP population in Portsmouth, and we know we don't have enough dentists. And community pharmacies are very linked to this, because ultimately community pharmacies are independent businesses, and they are going to be very and I think that's why this is happening actually. They're going to be impacted in the same way as other small businesses in Portsmouth and in the rest of the country. The reality, and I spoke to Simon about this, Simon Cooper, as Joe mentioned, he's our director lead for primary care, isn't he, which includes and pharmacists, yeah. And the reality is that a lot of these pharmacies are either consolidating or closing because they can't get the workforce. They're going to be impacted by the fuel, the increase on fuel, and we're going to see more and more impacted, which I suppose goes into the bit that Gerard rightly informs us from his contact, the reality is they are going to struggle, and we need to think more broadly how we're going to support, because it is, as well as being an independent business, as you rightly say, they are our fallback in terms of an NHS health service, and we do need to be aware, and it's not just, I think it's broader than perhaps we've discussed in terms of the P&A. We need to really think, as we support small businesses in the city, that actually community pharmacies are part of that. And also in the work we're doing around workforce with Health Education England and hopefully the university, we need to consider community pharmacies as well.
Come in, Chair. And yet they are making business decisions because of what's best for their business and how they can do that survival and consolidation. But you're right, we can't just allow it to be a business decision, because with the increase of electronic prescribing we could end up with the wrong outcome, which is less community pharmacists, and that won't help our primary care or that accessibility and that ability to get that lower level support and help. So we can't sit by and let the worst happen. We need to be putting those interventions in place. And as I say, off the back of the consolidations we've had mentioned, Simon is working with the team to look at are there different opportunities that we could do, are there ways we could look at it differently. Early days, but we keep our fingers crossed.
Thank you, everyone. Gerald.
Just one small thing. I think the other thing we need to be aware of is that this strategy means that the NHS refuses to allow pharmacies to open in some places. So the Tesco at Fratton wanted a pharmacy, masses of people go to it, and because of this strategy, they were not allowed to have one. Now that's something because that they would be in competition with one very close by, next door to Sunnyside, medical practice. I think I'm personally uncomfortable that decision to restrict the market took place, because we could have had additional pharmacy, but that wasn't allowed by the government, and I think that it must be a concern.
I think it's a really complicated issue, Gerald, and we know, don't we, if we look at small businesses across the board, not necessarily just in pharmacy, the more you see the big supermarkets, the big chains come in, the more threat that poses to the smaller independent businesses, and that will be the same in pharmacy as it is with greengrocers, etc. So it's a real challenge. I can't comment on that decision, but I guess what we will have as we move forward is more opportunity to influence and have some level of control over those decisions in future that have perhaps felt that they've been made outside of the city.
David.
Thank you. I think, Joel, I've followed the amendments that you wanted to make. I just wonder whether, I think really what we're seeking to do through those amendments is influence the role of the strategy in the decision making, either in the closure or the opening of pharmacies. And I guess it might be helpful for us just to get the delegation from this board just to check that is what those amendments are going to enable us to do. So, for example, I guess, the point about the, lost it. There should be the justification for reductions is really what we're wanting the strategy to be updated. It's just make sure that what we've got is a tool that can secure what we're after, and I think then that would need to be referred on to the ICB for them to be aware.
I think you're very sensible. If I give my amendments to Matt, if he needs to tweak, I'm sure I'd be very happy, and I'm sure if people are generally supportive of my suggestions, we should leave Matt editorial control. Minor editorial control.
Thank you, everyone. So thank you, Gerald, for your suggestions. Thank you for everyone's comments. I think the delegation down to the ICB could be, as we've suggested, be very helpful in the future. Matt, can I just ask, are the amendments as put forward, are they all okay to go in there? Do they fit in with the pharmaceutical needs assessment?
I believe so,
yeah. Okay, that's great. So on the, because obviously we don't want it to negate it in any way or get us into any legal issues. So we believe those okay. So with that proviso of the amendments as suggested by Leader of the Council, bring in the comments from others from what our Chief Executive has said in terms of with the delegation to the ICB. Is everyone happy with accepting those amendments? Fantastic. And therefore, formally, is everyone happy with those amendments in adopting the pharmaceutical needs assessment as set out in the papers? Yep. Brilliant. Thank you very much. That concludes our meeting. Apologies for the overrun. We had a very packed agenda today and really important stuff, but thank you so much everyone for coming today.